Hello everyone. Welcome to the 11th Practo Connect webinar. And this particular webinar we are doing it on updates in diagnosis and management of epilepsies. So epilepsy is one of the most common neurological disorders, which is often misdiagnosed and mismanaged, mainly because it's a difficult and a very complex brain disorder, and most physicians don't have the proper training to actually diagnose and manage this condition. So today we have two noted neurologists from India speaking on this particular topic, and I would love to introduce Lieutenant General C.S. Narayanan, my senior from college AFMC and a noted neurologist, presently with Manipal Hospitals, Dwarka. Passed out from AFMC in 1979, did his MD in medicine from AFMC in 88 and his DM in neurology from AIMS, Delhi in 1998. Awardee of 3 BSMs, Vishisht Seva medals during his service, a noted soldier, and presently with Manipal Hospitals, Dwarka. Also with us is Dr. P.N. Ranjan, a very well qualified and experienced neurologist with his MBBS from Gandhi Medical College, Hyderabad, and his DM in neurology from NIMHANS, Bangalore. Presently, a senior consultant in neurology at Apollo Hospitals, Indraprastha, Delhi. So we have the two of them with us. Thank you, sirs, for being with us. We will start with Dr. Lieutenant General C.S. Narayanan speaking on updates and in diagnosis and management of epilepsies. Over to you, sir.
Thank you, Nilesh, for your kind introduction. Yes, it is a great pleasure to be with someone who's from my college. I'll just share the screen.
Please.
So this topic given to me, of course, has got a very large ambit. It covers so many aspects, and given half an hour's time, it is not possible to cover all the aspects in great detail. But I'll do my best to simplify it as much as possible and give it in bite-sized bits. So while talking about epilepsy, we also first need to understand what a seizure is. A seizure actually is nothing surprising in the brain, because the brain is full of cells communicating with electrical discharges. It is an abnormal, excessive, and synchronous electrical discharge. So all these adjectives are important. It is abnormal, excessive, and synchronous. And if it lasts for more than 5 minutes, it is called status epilepticus. And if it has got a motor manifestation, it is called a motor seizure.
So your screen sharing is not done.
The screen sharing is not there.
Speech is not coming?
No, sir.
No, sir.
1 second.
Yes, sir.
But wasn't it okay earlier? Is it okay now?
No.
No, sir. No, the screen sharing is not visible.
Is it okay now? No?
No, we can't.
Not coming?
No.
Hello, hello, hello.
Yeah, we can hear you, sir, but was screen sharing. I think wrong window. Close all the other windows you have, sir. I think that would help.
I've closed all the. Is it okay now?
No, sir.
But we could speak to each other perfectly fine earlier.
Yeah.
Should we do one thing? Let Dr. Ranjan speak first. Second presentation. In the meantime, I'll set this right.
Yeah, we can do that. I mean, sir, we have 2-3 minutes. I mean, you can take your time. I shouldn't be a problem at all.
Okay, okay. I will rejoin again.
Right, please do that, sir.
Hello, can you hear me now?
We can hear you, sir. Hearing में कोई issue नहीं है. वो screen sharing का issue है सिर्फ. That's all.
When I'm sharing the screen, it's not coming.
Yeah, it's not. Yes, it's coming now. Yeah, we are here.
Can you hear me now?
Yes, we can see your screen and hear you. Please present, sir.
Yeah, good afternoon, everyone. I rejoined again, and I'm sorry for this small hiccup. As I said, epilepsy is a very complex topic, but given half an hour, I'll try to do my best to make it as simple as possible. And I was just describing a seizure, which is an abnormal, excessive, and synchronous electrical discharge from the brain. And if it lasts for more than 5 minutes, we define as status epilepticus. And a convulsion is nothing but a motor seizure. So we need to understand these words very clearly. And epilepsy, on the other hand, is defined as 2 or more unprovoked seizures separated by at least 24 hours. So here we need to understand why we say at least by 24 hours. There are a cluster of seizures which happen on the same day. It is not classified as seizure. And this word unprovoked is also very important. For example, if the seizure is provoked by some known condition like alcohol withdrawal, then we would not call it epilepsy. Or it is also defined as a person having one seizure and a high likelihood of having another seizure. And why does this happen in the brain? It is actually nothing but a balance between the excitatory neurotransmission and the inhibitory neurotransmission. And the balance between the two kind of determines whether a person is going to have a seizure or not. We all know that the predominant excitatory neurotransmission in the brain is glutamate, and it works through NMDA receptors. And the predominant inhibitory neurotransmitter is GABA, and it works through GABA receptors. So when there is overactivity of the glutamate NMDA complex, then we have a fast or long-acting activation, which predisposes to a seizure, as also when there is underactivity of the GABA receptors. The pathophysiology of this model is best understood by the thalamocortical interaction that underlies the typical Epsilon seizure. This circuit has got a normal oscillatory rhythm with periods of relatively increased excitation and relatively increased inhibition. So this is the model for a typical generalized epilepsy. And what about the epidemiology of epilepsy? So the lifetime likelihood of experiencing at least one single epileptic seizure is almost 9%. So it's not an inconsiderable amount. And the lifetime likelihood of receiving a diagnosis of epilepsy is almost 3%. So this is also quite high. However, the prevalence of active epilepsy in the population is about 8%, 0.8%. So what is a generalized seizure? In a generalized seizure, the focus is usually, as I said, somewhere in the subcortical region, maybe usually in the thalamus, and the pulses arise from the reticular formation and ascend to both the cerebral hemispheres at the same time. This is a very important concept for us to know. And in focal seizure, they arise from specific areas of one of the cerebral hemispheres. So these are the two broad categories of seizures that we talked about. Initially, the focal seizures were called partial seizures, but now the terminology has been done away with by the International League Against Epilepsy. So this is the classification. They've tried to simplify. This is the ILAE classification of 2017. So they tried to make it as simple as possible. So the first thing is we have to identify the seizure type. As I've already said, it could be as a focal, generalized. They've also included a category called unknown. And once we know the seizure type, then we go to epilepsy type. As we said, an epilepsy is 2 or more unprovoked seizure. So if they're continuously focal, then they're called focal epilepsy. If they're generalized, then they're called generalized, or combined generalized focal is also known, or unknown epilepsy is also known. And once we take all this seizure type and the epilepsy type, then we move on to classifying some of the epilepsy syndromes. I will touch upon this briefly later on. And it's also important to know that the etiology of all this seizure and epilepsy could be on the basis of structural lesions, some genetic lesions, some immune conditions. So on the right side of the graphic, all these are represented. And we also need to know the comorbidities with the patient underlying in the patient so that we can manage them effectively. So this is a very simple classification. This is the current classification given by the ILA. And so this is the expanded version of the same. So the focal onset seizures predominantly are of two categories, in which the patient is aware, meaning is fully conscious, or in which the patient is not fully conscious. If the patient is not fully conscious, it is what was earlier called as complex partial seizure. That terminology been dispensed with, but even neurologists continue to use this term quite often. So these focal onset seizures could be of motor onset, in which case there could be automatisms, atonic, clonic, hyperkinetic, myoclonic, so many types of motor onset focal seizures. And they could also be non-motor onset. This is all very important to know, because all of us can see the motor manifestation of seizure very clearly when we look at the patient. But certain things like cognitive dysfunction, emotional lability, or a sensory disturbance can also be a manifestation of a seizure. And if we do not know this, we can misdiagnose a person who's having seizures or epilepsy. Generalized seizures, again, have all these motor manifestations and also certain non-motor manifestations. And we must always remember that focal onset seizures can proceed to become generalized tonic-clonic. They can spread, the impulses can spread to make it generalized tonic-clonic. So what are the motor manifestations of a generalized seizure? I have simplified it in this slide. So the motor manifestations either are tonic, clonic, tonic-clonic, atonic, or myclonic. We'll talk about briefly about all these types of seizures because none of these is uncommon. And when tonic and clonic seizures occur together, it's called a tonic-clonic seizure. And this is the most common type of seizure that we've also always seen in practice. So what happens in a generalized tonic-clonic seizure? So there is sudden contraction of the vocal cords, and this causes an involuntary scream or cry. So this is the onset of a generalized tonic-clonic seizure. Then there is contraction of the ocular muscles, which causes a prolapse of the eyes. There is contraction of the oropharyngeal muscles, which causes pooling of secretions in the oropharynx. We've all seen a person who's having a generalized seizure, who's got a lot of pooling of saliva in the oropharynx and in the mouth, and also kind of drooling from the sides of the mouth. Then there's contraction of the jaw muscles as well. And this causes a tongue bite. And lastly, because a person loses consciousness and a large part of the brain is involved, the person can have urinary or fecal incontinence. So this sequence of events is what is called a generalized tonic-clonic seizure. But what is equally important to know that the patient thereafter goes into a post-ictal phase wherein the consciousness is impaired for minutes to hours. Again, we know we've all seen patients who are a little confused for a few minutes. But we also must know that if the person has had a couple of generalized tonic-clonic seizures, he may not be in full senses for several hours on end. And during this phase, actually, we may entertain so many other differential diagnoses, but must always keep the possibility that this person has had a seizure. Sometimes, actually, this may be the only indication, because we may not have witnessed the generalized tonic-clonic part of the seizure, that the person has had a seizure in the recent past. The second important category of generalized seizure is an Epsilon seizure, and this is usually seen in children. This is a pretty dramatic thing to see as well. When you're kind of sitting, the patient is sitting in front of you in the office, they have sudden brief loss of consciousness. And this could be from seconds to minutes. Usually, actually, it is only seconds. And the most important thing to note is there is no change in postural muscle tone. So the child is actually sitting perfectly erect and there's nothing else happening, but he blanks out. And so these episodes can occur dozens or even hundreds of times per day. And so the persons who are attending to them, and since they're usually of the school-going age, so the teacher complains that the child has been staring into space or daydreaming or inattentive. Actually, they kind of, over a period of time, lose the connect of what is going on in the class. So their scholastic performance also deteriorates very rapidly. And because of this, these children are very often misdiagnosed as having attention deficit or hyperactivity and various other things like that, whereas it is a very simple diagnosis and a very simple type of seizure to treat. So the treatment is very rewarding because the child starts studying much better and the results start improving very soon. The other type of generalized tonic-clonic seizure is an atonic seizure when there is total loss of muscle tone in the body, and this causes a postural imbalance, and the person actually dramatically falls down, many times face down, and so these persons very commonly kind of injure their face. And we've all seen in practice that there are several of these patients who go about wearing helmets, because a very kind of frightening condition, because without any notice, the person completely falls down face flat on the ground and injures his face. The last category that I'm talking about in the myoclonic is myoclonic seizure. These are sudden, rapid, shock-like muscle contractions, wherein a person it's more like a startle. And we've all seen this type of a seizure, which happens in a condition called juvenile myoclonic epilepsy. The difference between a clonic seizure contraction and a myoclonus is a clonic contraction much slower. Each contraction happens over a period of 1 to 2 seconds, whereas a myoclonus is much faster. It is an electric shock-like contraction lasting only for about 0.1 seconds. What about focal seizures? We've already spoken that some focal seizures do not impair consciousness, and these are called, earlier were called simple partial seizures. And these kind of begin abruptly and they end abruptly. There is no postictal phase. Whereas if there is a impairment of consciousness, these are called complex partial seizures, and there is a postictal phase in these patients. So the two broad categories, generalized and focal, we've discussed a little bit about both of these categories now. And focal seizures, like I said, if it arises in the primary motor cortex, then there can be kind of jerking of the limbs, or either the upper limb, the lower limb, or any part of the body, for the mouth. And so these are pretty obvious to the attender who is kind of seeing the manifestation of the seizure. However, it is also possible, very clearly, that these seizures can arise from any other part of the cerebral cortex. For example, if it arises from the occipital cortex, there are no motor manifestations, but the person has got some visual symptoms, like they can see flashes of light and such things like that. So unless the patient explains it to you very well, you may actually miss out that the person is talking about a focal seizure. So what are auras? Auras are nothing but focal seizures. So auras kind of precede a generalized seizure, so which is preceded by a focal seizure, and then kind of goes on to become a generalized seizure. So aura is a manifestation, is the focal part of a generalized seizure. And these could manifest as subtle muscle movements called automatism. They can have chewing of the mouth, lip smacking, rapid eye blinking, but they can also have some non-motor manifestation. Like I said, they could have unusual smells, like, or one of the common things described as burning rubber. They can have a rising sensation in the abdomen, or they could have feelings of fear or deja vu. Deja vu, as we all know, is a kind of a new sense of familiarity of something that one has not seen before. Like some kind of an experience that you always think has happened before, which actually has not. That the corollary of this is a condition called jamais vu. So these are kind of very, very interesting, and a lot has been written in both fiction and non-fiction about these kind of persons who've got temporal lobe seizures and actually involved in crimes and such things like that. It's a very interesting part. So auras are a very interesting aspect of this whole spectrum of seizure disorders. And subsequently, after the person has had a focal seizure, the person can go on to have what is called a Todd's paralysis. That means a temporary paralysis of the affected extremity. For example, the person has a left arm involvement due to a focal seizure. That arm stops working for a few minutes or a few hours even, and that is called the Todd's paralysis. So as I've already said, focal seizures can spread and cause a generalized seizure. And this is called the secondary generalization of a focal seizure. So how do we know? So many times we see only a person having a generalized seizure. So how do we know if this person has got a primarily generalized seizure or a secondary generalization? Some of the clues are a history of aura, unilateral shaking, that means it arising from one hemisphere, turning of the head to one side, that also gives an indication of laterality, and the presence of Todd's paralysis. So if you go to the history, and if you're very careful in taking the history, these are all manifestations of focal seizure preceding a secondary generalized seizure. However, The caveat is that absence of any of these features does not include a focal seizure. So maybe we may have to investigate these patients further to find out if they've got some focus in the brain or not. So many of these kind of also seizure types are part of some syndromes, and some of the localization related epilepsy and syndromes are the benign childhood epilepsy with centrotemporal spikes, childhood epilepsy with occipital paroxysm, and mesial temporal lobe sclerosis, which is not uncommon at all. So I have just named a few of the more common ones. So some of these syndromes are also associated with localization related or focal seizures. There are a host of conditions and syndromes which are associated with generalized seizures, and I'll just quickly run through because they're also important, and all of us do see them in practice off and on. There could be benign neonatal convulsions, benign myoclonic epilepsy of infancy, childhood absence epilepsy, which is called pycnolepsy, juvenile absence epilepsy, and a very important condition called juvenile myoclonic epilepsy, which is a very important condition for two reasons. Firstly, it is common. Once we pick it up, there is a very nice treatment available for it. And if we don't diagnose it properly, we end up giving all the wrong medication and make the condition worse. Symptomatic infantile spasm, the Lennox-Gastaut syndrome, epilepsy with myoclonic astatic seizures, and epileptic myoclonic absences are there to complete the list. So we must know that these are all part of syndromes of generalized epilepsies. This also is a very important thing to understand, because in practice, no one's going to come and tell you that I'm having a seizure. So these are all paroxysmal events which are happening. The person is saying that I was perfectly fine and something happened to me and this is what happened to me. And so not all paroxysmal events are seizures. The most important mimic is what is called a syncope. A syncope could be a simple faint, or in some conditions like in cardiac arrhythmia, the person can faint. Or the person could be having a non-epileptic spell or a non-epileptic seizure, as we call it. And these are due to functional neurological / psychiatric disorders. And these are also not at all uncommon. The important thing to remember is that many persons with non-epileptic seizures also have two seizures as well. So this is like a confuses and confounds someone who's treating these patients. So we have to treat both aspects. A TIA could also be a paroxysmal event. Migraine and vertigo, we've all seen, are paroxysmal events. Sometimes they very, very closely resemble a seizure. For example, migraine has also got an aura, and a vertiginous patient can also lose consciousness. So all these conditions can definitely mimic seizures. So quickly running through the list, and these are only the commoner conditions that I'm talking about. A syncope, like I said, there could be a prodrome, whereas in a seizure, there is usually no prodrome of lightheadedness or sweating. There could, but the one important thing is to remember that even in a syncope, there could be some tonic-clonic movements. So this should not be the sole differentiating factor between a syncope and a seizure. In a psychogenic seizure, history taking is very important. They could be under some stress, there could be a trauma or childhood abuse or something like that. And some of the common motor manifestations of a non-epileptic seizure are pelvic thrusting and some very, very typical phenomena. Vertigo usually lasts for minutes and days, and it kind of varies a lot with the position of the patient, and more importantly, the position of the neck. Whereas one important thing why it can be confused as seizure, because the person can actually become semi-conscious in these conditions as well. TIA lasts for a few minutes, and they're usually accompanied with other symptoms of stroke, like facial drooping, a slurred speech, and the arm drift and things like that. Migraine, particularly those migraines which have got auras, can be confused with seizures. So what are the important cause of seizures? So this is again a slide by the Indian Epilepsy Foundation, where Dr. Nilesh has worked extensively. And so the most important cause is actually unknown. So 40% of seizure and epilepsies, we don't know the cause. So they're presumed genetic, I suppose, but we don't label them as such until the gene is identified. The next second category depicted in yellow here, the genetic generalized epilepsies. So the conditions which used to be called primary generalized epilepsies are now called genetic generalized epilepsies. They constitute a vast number. I've already listed some of these conditions. The other conditions that we're talking about, whether they're vascular malformation, traumatic brain injuries, dementia, perinatal instill, neoplasms, immune disorders, infectious, and such, they kind of differ with the age in which we see the patient. For example, in a very small child, a perinatal insult would be the most common condition. In a young adult, it could be a traumatic brain injury. As a person becomes slightly older, brain tumor takes over. In the later age group, it could be a stroke, that is, and vascular malformations. And also in the last stages of life, dementias also like have seizures as a manifestation. So it's a very small proportion of the overall ambit of when we see all the causes of seizures. So seizures are just a symptom of some underlying brain problem. So for example, there's an acronym called vitamins. You can use any acronym that you want. So V here stands for ischemic or hemorrhagic stroke. That means the vascular event. Or it could be a symptom of an infection like meningitis, encephalitis, or brain abscess. It could be a manifestation of trauma like a penetrating traumatic brain injury. It could be a symptom of the other T here is toxins. This is very important. Many drugs lower the seizure threshold. Some of the common ones that we use are certain antibiotics like cyclosporins and various other categories of drugs, and also substance abuse, which is not uncommon. And we tend to ignore this aspect in our practice, but you must always do a urine drug screen when a young person presents with a seizure. Alcohol withdrawal is very common, and it can present very abruptly and dramatically with a seizure. And some of the medication that we give, like bupropion, is very commonly given for individuals with eating disorders like anorexia and bulimia. There's a host of others. So there's just an example to tell you that symptom is just a seizure. There's a symptom of various underlying conditions. It could be a part of some autoimmune nervous conditions like vasculitis or autoimmune encephalitis. An important thing that remember is some metabolic conditions. So electrolyte imbalances like hyponatremia, hypocalcemia, hypoglycemia, hypothyroidism, or any of these systemic disorders like hepatic encephalopathy, uremic encephalopathy, or Wernicke's encephalopathy can present with seizures. Out of which I think in adult practice, at least hyponatremia should never be mistaken. We must always be on the guard. When a person comes to you with an obtunded sensorium and possibly having had a seizure, always estimate the serum electrolytes, and of course, hypoglycemia. So this is always the first step. The first step in correcting a person who comes to coma in the casualty will be to give B12 to correct Wernicke's encephalopathy, which is a possibility, particularly in patients who are undernourished and who are alcoholics, and also give 50% dextrose so that the hypoglycemia part is taken care of. So now coming to the management. So you've got this patient who's come to you in the office and says he's got a seizure. So if the person has, the seizure is happening for the very first time, what do? So you do have to rule out other conditions with paroxysmal events. Like I said, it could be a syncope. So we can do we can, of course, all these things, you have to take a proper history. That's an underlying theme everywhere. But then you go on to do some routine investigation like an ECG. If it is a cardiac related syncope, you can pick it up. Then you also need to rule structural abnormalities in the brain by doing a CT or an MRI. And also rule out certain other possibilities that I just talked about by doing infection, by doing a complete blood count, electrolytes, liver function, serum glucose, toxicology screen, and in pregnant, in young women of the childbearing age, we need to do a pregnancy test as well. So after having done all these, and the person has had only a solitary seizure, and we come a cropper with all these investigations, they're all normal, what do we do? So these persons are ideally not treated with anti-epileptic drugs. So a person with a solitary seizure, even if it is a confirmed seizure and not one of those other paroxysmal events, need not be treated. The risk of having a recurrence is about 15 to 70% in these patients. And it is 70% in case one of these investigations are normal. It is on the lower side when all these investigations are normal. So we can actually observe these patients, but we must tell them to avoid certain conditions which can precipitate seizures, like alcohol withdrawal, sleep deprivation, and things like that. So we give them this advice and tell them to go home. The second category is the person has already had a seizure. So like I said, by definition, a person who's come to you and says that he's already had a seizure, that means he's got epilepsy. So these patients could be already on medication. Then we need to assess them for the adequacy of therapy. So we need to find out if the patient has taken the medication, change the medication doses, started a new medication, experience side effects. So all about whatever drug therapy is going on. We can also measure the serum level. And if they're low, we can increase the dose or change the medication. And if they're normal, then we can think in terms of changing the drug altogether. So the approach is different when the person presents for the very first time or if it is a confirmed case of epilepsy. So what are the other investigations that we can do to kind of diagnose these persons with epilepsy? One of the most important medication, as we all know, is an EEG. It is very routinely done. You must know the interictal EEG. That means an EEG recorded when the person is not actually having a seizure, as against the ictal EEG, which is recorded when the person is actually having a seizure, which can happen only when we are doing a long-term recording in the neurology department. But most other situations, we do a interictal record. So there's a classical pattern in Epsilon seizures, which we call 3 hertz, that means 3 per second spike and wave pattern. So once we see this, we are very sure that the child is having an Epsilon seizure. And these seizures can be brought about by inducing certain mini seizure by provocative maneuvers such as deep breathing, or also called hyperventilation, photic stimulation, that is, we give some bright and flashing lights, sleep deprivation. So the seizures can be induced and we can bring out these changes on the record by doing these maneuvers. And an EEG can also tell us whether the seizure is generalized, because these electrodes are placed in such a manner that if it's a generalized seizure, it will be recorded in all the electrodes, recording from all parts of the brain. Whereas if it is a focal seizure, it will record only from one part of the brain. In a vast majority of patients, of course, we must not rely only on the EEG for the diagnosis of epilepsy, because a negative EEG does not exclude epilepsy. So this is very important to understand. It is not a confirmatory test, but it is an adjunct test to help you with the diagnosis. So how do we treat these patients? So either we treat them with medicines, which are of a very wide variety. I'll give a very brief overview of these medicines that we use. We can, about 60 to 70% of these patients do very well with medicines alone. And the remaining 30 to 40% of patients do not do so well. Some of them become refractory, about 20%. So these refractory patients may do better if we add on more drugs. So we start off with one drug, add another, go to 3 drugs. So some of these patients may, about 10 to 15% may respond to the addition of new drugs. However, there is a certain category which does not respond to any kind of medication. And these kind of patients should be ideally referred for epilepsy surgery. And this can remove the cause of seizures in some types of seizures, particularly in one condition that I spoke to you, which is not uncommon, called mesial temporal sclerosis. There are also other types of epilepsy surgeries. This is outside the purview of my present talk, but we must know that drugs are available, surgery is available. The third modality is nerve stimulation. This is by a device, and we stimulate the vagus nerve, and this is also kind of used only in persons with refractory epilepsy. And in certain types of seizures, particularly in children, we have the option of a ketogenic diet, which forces the body to burn fat. And so these are some of the most important modalities of management of seizures. Some pediatric neurologists swear by the use of ketogenic diet, though adult neurologists very rarely resort to this modality. So in quickly, how do we diagnose? We have to take a detailed clinical history, which includes an eyewitness account. I resort to mobile video recording. We must use all the technologies that is available to us judiciously, and this is so much better than a long-term video recording when the patient sleeps in your office, or in your hospital for 2-3 days. So on the other hand, the event can be recorded by alert attendant, and they can show it to you in the next visit to the hospital. This is a hugely useful thing. We must ask specifically for NORA, the preservation of consciousness, post-ictal state, and stereotypy. Stereotypy is very important, because if the seizure got a one focus in the brain, And so the same focus fires repeatedly. So the manifestation is also very stereotypical. For example, like I said, a non-motor manifestation or temporal lobe seizure could be abnormal smells. They have a smell, they feel that they are smelling burning rubber. So every time the person has a seizure, they'll feel the same smell. So that is important. And of course, systemic examination is important, as is always in medicine. And we may pick out certain neurocutaneous syndromes by this. So what are the anti-epileptic medications that we have? And I'll not go into the depths of this, a few more slides only. So firstly, you must choose the medication on the basis of the type of the seizure. We've gone to great lengths in explaining that there are various types of seizures. We must go to whatever extent possible to find out what type, focal, generalized, if focal, what type of focus, if they generalized, is it part of a syndrome? So all these are very important. So the type of a seizure determines what type of anti-epileptic medication that we're going to use. Then the convenience of the dosing schedule. Some drugs are given once per day, some twice per day, some mostly twice per day, and some drugs very rarely can be given more than that as well, many more times in a day. And we must also keep in the side effects, because all these drugs do have some side effects, and they're peculiar to each category of drugs. We must be fully aware of them. We must counsel the patients briefly, one or two. For example, valproate can cause tremor, it can cause alopecia, it can cause weight gain, and each of these side effects can be bothersome to the patient. Levetiracetam, which is one of the most commonly used medications, can cause neuropsychiatric manifestations, and each of one of the other drugs can also have side effects which we must be familiar with. So for generalized seizures, we generally end up choosing levetiracetam, valproic acid, lamotrigine, or topiramate. For Epsilon seizures, if it occurs singly, and that means it is not mixed with any other seizure variety, ethosuximide is a drug of choice. Fortunately, it's been made available in India now. But more often, it is also associated with other seizure types like Clonic Seizure, in which case valproic acid becomes the drug of choice. For focal seizures, we can choose carbamazepine, phenytoin, or lamotrigine, or some of the newer anti-seizure drugs. I would not like to call them anti-epileptic drugs, because no drug kind of addresses the root cause of the seizure. They just reduce the chance of the person having a seizure again. Peculiarly in pregnancy and eclampsia, magnesium sulfate is the preferred modality rather than any of the standard anti-epileptic drugs that we otherwise use. And there are several trials to show that it actually works. So having said all this, having given the person the medication, we must also tell them that they must avoid being in dangerous situations like heights, swimming, driving a vehicle. And when they're actually having a seizure, we must, firstly make sure that the attendants don't resort to stupid things like putting a spoon in the mouth, which is not uncommon in the Indian village side. The only thing that they need to do is calmly kind of turn them over to one side so that they don't aspirate their own pool secretions in the oropharynx. The mechanism, again, I will not go through the details of the slide, but as you know, there are several anti-epileptic drugs. Firstly, at least about 15 to 20 of them, each one having a different mechanism of action. As neurologists, of course, we have to be fully aware of how each one of these drugs acts, because they're all associated with a specific efficacy and safety profile and adverse effect profile. So we must be familiar, but suffice to say that there are a whole lot of drugs, and more drugs are being in the pipeline. So maybe one day we can expect some drug which is very efficacious and very, very few side effects. But unfortunately, that is not the case as of now. So a couple of more slides. What happens when a person comes to the emergency department? So if the person has a seizure which lasts for more than 5 minutes, in the very first slide I said it is defined as status epilepticus, or if there are successive seizures without recovery of consciousness in between, that is also called status epilepticus. This is a very important condition because they are at a very high risk of permanent brain or cardiac injury. So the first thing that to do is, of course, address the airway breathing circulation, as in any other medical emergency. We must give oxygen, cardiac monitors, place blood pressure, and vitals. All these things are very important. And as I said, immediately give a combination of thiamine and glucose, thiamine followed by glucose. I will not go into the detail, but that is the order in which it is given. This addresses both Wernicke's and hypoglycemia. The next thing that immediately one must give, that is within seconds of the person coming to casualty, is give a dose of lorazepam. This is a long-acting benzodiazepine, followed quickly by phenytoin. We must give both. Lorazepam acts quickly and the duration of action is also prolonged, followed by phenytoin because it's got a sustained effect for several hours. So we must load the person with phenytoin. If they don't respond, give another dose. The time frame here is very important. Within minutes of the person coming to the casualty, we must quickly take him to the intensive care situation within half an hour. That is the timeline given. And we must intubate and start anesthesia with midazolam, propofol, pentobarbital. So this is an important concept. I cannot emphasize it very much. Many of us are guilty of delaying this process for quite a bit. You know, the person is lying the casualty for several hours. You get a call, you go there, see, but that it doesn't work. The intubation, anesthesia, propofol and all that should be started within the first half an hour, and also under continuous EEG monitoring, because while anesthesia kind of controls the motor manifestation of seizure, the person could be having what we call non-convulsive seizures, which also need to be addressed and which also can lead to permanent brain damage. So the person should be given anesthesia with continuous EEG monitoring. So is there a genetic basis to seizures is a question that many of your patients will ask, and you must tell them yes. There are many seizures could be part of several syndromes that may actually include intellectual disability, brain malformations, and also multiple congenital anomalies. So it is not only the seizure which is the predominant part of presentation of these kind of patients. However, there can be, like I said, it could be a part of some neurocutaneous syndrome like tuberous sclerosis, the Sturge-Weber syndrome, some metabolic disorders like lysosomal storage disorders, mitochondrial disorders like MELAS and MERF, and single gene mutation. This is an important thing. This ADFNLE stands for autosomal dominant frontal nocturnal lobe epilepsy and the Dravet syndrome in children. Because these single gene mutations, which call seizures, in the absence of any other syndromic symptoms and signs, can give important insight into the pathogenesis of seizures. So some specific epilepsy syndromes, like I said, I will not go to the depths. It could be infantile spasms and West syndrome, very, very common in children. Pediatric neurologists are very, very familiar with this, and they are very important for two reasons. Firstly, they are common. Secondly, they are difficult to treat. Tuberous sclerosis, again, can be seen in young children, but of course, in practice, you do end up seeing some adults also with this. It's a very important thing because once you've seen all the neurocutaneous manifestations, it is not very difficult to identify these patients. The Ashley macules can be identified with ultraviolet lamps, and the infantile spasm, which happens in infants, can be treated with ACTH. And vigabatrin is another anti-epileptic which is specifically used for tuberous sclerosis. Other syndromes exist. Again, many of them have developmental delay, multiple seizures, spikes, and specific changes in the EEG like the Lennox-Gastaut syndrome. One quick word about juvenile myoclonic epilepsy, though. It is common, and this myoclonus usually happens when the person gets up from sleep. This getting up from sleep could be either in the morning or even after an afternoon nap. So they have these kind of jerks, quick jerks, and sometimes it is strong enough for something they're holding in their hands to fall off, like a toothbrush. And the person themselves don't think it's very important. Unless you ask them specifically, they may not come out with it. And it starts off usually in adolescence. And of course, it is very well treated by certain drugs like levetiracetam and like sodium valproate. And the important thing to know is the treatment in these conditions, in this condition, is lifelong. This is one of the conditions, unlike other types of seizures where treatment can be lifelong. But the moment you discontinue the anti-epileptics, even after several years of seizure freedom, the person goes on to get another seizure. So juvenile myoclonic epilepsy, an important condition. You can read up more about it. Landau-Kleffner syndrome. All these, so each of these conditions is very characteristic, very fascinating. And if time permitting, we'll talk about these in another meeting. Febrile seizures, again, important in children. One must know that they're very infrequent, happen between 6 months and 6 years. and usually follow a respiratory infection. And many of these children have a family history of seizures, and in some of them there is a pre-existing neurological disorder. There are two types: simple and complex. Simple febrile seizures, no laboratory investigation, no imaging studies, risk of epilepsy is very low, and they do not have to be treated. This is all that you need to do. And the simple seizures are classified as generalized tonic. They are always generalized tonic clonic, always last less than 15 minutes, always only once in a 24-hour period, and do not result in a neurologic deficit. Everything else follows into other category of complex febrile seizures, and they do have to be treated. What about prognosis? The prognosis of a single seizure is not that bad. Nothing happens, so you have to reassure the attendants that nothing will happen for a single solitary seizure. You just need to put the patient on one side and make sure they don't aspirate. However, the fact that they lose consciousness can put them in a big predicament depending on the situation that they are. So this can unpredictably result in morbidity or even mortality. For example, a person has a seizure when dry, definitely can end up with a mortality. SUDEP is an important condition. It's called sudden unexplained death in epilepsy. It is not common, but it is another important thing because they do die, even if they're in an observation in a hospital situation for no rhyme or reason. It happens very infrequently, but it is a very disconcerting thing when we see a person who is perfectly fit, a young adult who is being observed in the hospital under your care, suddenly loses his life. Lastly, I'll finish. I'm very thankful to Nilesh for inviting me to speak on this forum today, because very soon, in 5 days' time, we're going to have the World Epilepsy Day, which is actually a day where everyone kind of exchanges notes on the various aspects of epilepsy, the patient education aspects, and where we are and what the future lies ahead in the management of epilepsy for all of us. One slide that was left out of specializations we need to know. I'll not again delve into this. And with that, I thank you all for your kind attention. I'd be very happy to answer some questions. I know I've rushed through, but I hope some of it did sink in, and I'll be very happy to answer any questions that you may have.
Can't hear you.
Can't hear you, Nilesh.
Nilesh can't hear you.
Yeah. Thank you, sir. I know it was a huge task asking you to cover epilepsy diagnosis and management within 30 minutes. I mean, this is something which could take us 6 months minimum to understand. But thanks a lot for your lecture. We do have a few questions around the definitive diagnosis of epilepsy, but we'll take them all up in the end.
Sure.
Right now, I would like to invite Dr. Ranjan, sir, please. In the last 1 year, COVID has wreaked havoc with everybody's life, especially people living with epilepsy. They've had issues with increased number of fits, loss of access to medicine, loss of access to consultations. So COVID itself has had effect on everything, including epilepsy. So could you please shed some light on this, sir, please? Yeah, we can see your screen, sir.
Can you see my screen, please?
Yes, sir, we can.
Thank you, Nilesh. Thank you, General Narayanan. It's a pleasure to be here today. And Dr. Narayanan has made my job a little simple, but not that simple, because I would like to stress what has happened with epilepsy, and Nilesh rightly said. Do COVID by itself is the cause of epilepsy, or the epilepsy has been precipitated in patients who have had a COVID infection? This is, of course, a repetition of the same slide that you talk about epileptic seizure, and you talk about epilepsy, and epilepsy is a condition which seizures occur continuously. You use the word epilepsy. It's a major problem in the developing world like ours, more a problem in the rural areas. Prevalence are higher in developing countries. And unfortunately, the incidence is highest in children and childhood. The burden of epilepsy is enormous. It's a major public health problem. 50 million people worldwide, 500 million people involved as family members and caregivers. 80% of epilepsy is in resource-poor developing countries. We are a developing world. We are now a poor developed country. Because the developing countries and the developed are not well equipped with medical, social, economic challenges which are posed by epilepsies. The unfortunate part is that there is a social stigma. There are myths and misconceptions. Developed countries have high prevalence and incidence rate, and the lifetime prevalence of epilepsy is very high. In India, the prevalence is 5 per 1,000, rate of 50 per 100,000. India has over 1 billion inhabitants. 500,000 get it annually, and India and China account for more than 20% of the people with epilepsy. This slide you've just seen, Dr. Narayanan, that what are the basic causes of a newly diagnosed epilepsy, 61% being cryptogenic, where we do not know the cause, alcohol, vascular malformation, trauma, tumors, and other causes. The commonest types of seizures are the complex partial seizure, the simple seizures, myoclonic, and of course, largely the unclassified seizures. When we are treating an epilepsy, we must know about what is the etiology and the precipitating factor. We must take the family history, history of trauma, fever, look at metabolic abnormalities, degenerative diseases like Alzheimer's disease, and more interestingly, photosensitivity and auditory stimulation. Now, it's not very easy to treat epilepsy. I'm not trying to tell you that you should not treat epilepsy, but if we all treat epilepsy in a more scientific way, we will get much better control of epilepsy, lesser side effects of drugs, and we will really know how long we need to treat this particular patient. So what does this mean? What does this imply? The International League Against Epilepsy in 2017, and this is what I do. When a patient comes to you, please try to evaluate whether he has a focal seizure, he has a generalized seizure, whether the focal seizure is associated with awareness, a lot of consciousness. Is it focal? Is it generalized? So once you know what is the seizure type that you're dealing with, you will be using the right drug to treat the seizure. Now, once you have made up your mind that yes, I'm treating a seizure, this seizure, then comes a broader classification, which is called the syndromic classification. The coronavirus COVID-19 outbreak, which started in Wuhan, China in late 2019, and is rapid spread globally. Vaccines have recently been developed and are being administered in some countries, but the widespread use are not sufficient, and the battle against COVID-19 is protected, and people need to adapt a living under the influence of this disease. Epilepsy is a common neurological condition characterized by spontaneous recurrence of unprovoked seizures. Various effects of COVID-19 epilepsy have been studied in recent months. As clinicians, we need to keep up with the daily updates in the evidence regarding interaction between COVID-19 and epilepsy. If you look at this picture of COVID-19, epilepsy and the associated issues that may be affected by COVID-19 coronavirus. What is the impact of COVID-19? The education, the direct association, the prevention of COVID-19, EEG, epilepsy care, treatment, mental health, and dealing with specific diseases in disorders. So this is what the COVID-19 and has an impact on epilepsy. I will not bore you with this busy slides, but this slide in front of you is telling us the impact of COVID-19 on patients with epilepsy and factors potentially associated with vulnerability, anti-epileptic drugs, COVID-19, and the coronavirus disease. If you see the first study only, which is from El-Kotli from April from Saudi Arabia, there was a seizure worsening in COVID in 29.5%. You go to the next study from Italy, 18%, Herring, 8.6%. El-Kotli again from Saudi, 44.4%. So this is what, that the seizure worsening is occurring during the COVID-19 infection period. As a result of which, we need to understand, do we just increase the anti-epileptic? Do we treat the complications of COVID-19? Or do we change the anti-epileptic because of the interaction between the drugs used for COVID-19 and the anti-epileptics? So, patients with epilepsy, as with the general population, may be treated for COVID-19, and clinicians need to be aware of the fact of the potential for interaction with AEDs and COVID-19 therapy, which I just said. Two, importantly, caution should be exercised, as interaction can either diminish or enhance the effectiveness of drug and cause side effects. Such combinations of AED and COVID-19 therapies, for example, the combination of S-carbazamine, lacosamide, and atenolol, opinavir, ritonavir can cause potentially serious arrhythmias, and the potential for such interaction thus requires special attention according to the International League Against Epilepsy. Balancing the anti-epileptics in COVID-19 era. Drugs such as carbamazepine, phenytoin, phenobarbital, which are the commonly used drugs in the smaller cities and in the rural population of our country, should be used with caution when given in combination with remdesivir, which is often used to treat COVID-19. Notably, levetiracetam has been shown to be largely unaffected by COVID-19 drugs. So this is what I said, that if you have a patient who's throwing seizures, you have no choice to give remdesivir, and on that he's on carbamazepine, you need to change the anti-epileptic. So consideration should be given to switching to anti-epileptic drug with less potential for interaction with patients who may need COVID-19 treatment, number one. On the other hand, changing the AED regime has been reported as a factor with increased seizures. So you're a problem both sides. If you're giving a drug, you're doing some interaction. And it has also been known that if you change or if you decrease the dosages, the patient may go into seizures. But we all know with the COVID-19, what is called a cytokine storm. Like all 6 previous beta coronavirus, COVID-19, has the ability to enter the nervous system and cause neurological symptoms, number 1. Number 2, the angiotensin converting enzyme provides the entry route for the coronavirus to infect human cell. These receptors are found mainly in the brainstem and are responsible for regulating the cardiovascular and respiratory functions. Like both the acute respiratory syndrome SARS and the Middle East respiratory syndrome MERS, COVID-19 may also enter the brain directly through the olfactory tract without the need of the ACE2 receptors. So there are the 2 ways which the COVID virus would directly enter the brain, one being through the ACE2 receptors and the other being directly through the olfactory tract. After the invasion, the virus triggers reactive astrogliosis and activates the microglia and induces large inflammatory cascade. Virus entry into the central nervous system leads to the release of pro-inflammatory cytokines, IL-6, TNF-alpha, nitrous oxide, prostaglandins E2, free radicals, and causes chronic inflammatory and neural hyperexcitability, leading to seizures and death. So this is where there is a dreaded complication of COVID, and it enters the brain, causes seizure and death. The COVID-19 epilepsy causes a breakdown of the blood-brain barrier. Activated glia are not only the only source for the production of inflammatory cytokinins in SARS-CoV-2 infections in the brain. Cytokinins, such as IL-6, TNF-alpha, can enter the brain through passive and active transmission. Endothelial cells in blood vessels play an important role in the mechanism of blood-brain barrier permeability. On the other hand, the blood-brain barrier breakdown causes the migration of blood cells and proteins, such as albumin, which disrupts the osmotic balance in the central nervous system and causes seizures. Patients infected with COVID-19 have shown some coagulation abnormalities, which are now well worked out, characterized by prolonged prothrombin time, increased levels of D-dimers, and diffuse intravascular coagulopathy. Chang and al. From China reported that 71.4% of the survivors and non-survivors, that's 0.6% of the survivors of COVID-19 showed evidence of disseminated antivascular coagulopathy. The non-survivors and the survivors. The post-ischemic and stroke seizure is one of the causes of epilepsy. Oxidative stress plays an important role in severe SARS acute respiratory syndrome coronavirus infection. Oxidative stress is closely related to mitochondrial dysfunction, and the role of mitochondria in the pathology of COVID-19 disease has been confirmed. There is an interplay between mitochondria, oxidative stress, and inflammation, 3 deadly things which are occurring in a COVID-19 infection. That is the interplay between mitochondria, oxidative stress, and inflammation. Seizures are the most important clinical symptom of electrolyte imbalance commonly seen in COVID infections and are more common in patients with hyponatremia, hypocalcemia, and hypomagnesemia. In these individuals, successful treatment of seizures begin with the accurate diagnosis of the underlying electrolyte imbalance. A growing body of evidence shows the neurotropism is one common feature of coronavirus. One study specifically invested the neurological manifestation of COVID-19 and could document CNS infection in 25% of the patients. 13% had headache, dizziness, impaired consciousness, cerebrovascular disease, ataxia, and what we are interested in is post-COVID epilepsies, which was about 0.5%. There is also a report on meningitis and encephalitis associated with SARS-CoV infection accompanied by seizure, where the SARS RNA was detected in the CSF. Another report describes a patient affected by COVID-19 whose primary presentation was a focal status epilepticus, which Dr. Narayanan has just talked very much in detail. Therefore, it is reasonable to expect that some patients with COVID-19 infection develop seizures as a consequence of hypoxia, metabolic derangements, cytokine storm, organ failure, or even cerebral damage that may happen to people with COVID-19 infection. Please look at this picture, which shows the mechanisms of seizures associated with COVID-19 infection. Neuroinvasion yet to be confirmed, but when you're shown the presence of the COVID virus in the CSF, you would presume that there is neuroinvasion in COVID-19. Hypoxia, organ failure, metabolic derangement, and never forget the therapeutic interventions, the drugs which we all use and we would still use for COVID-19 infection. The virus can cause complicated disorders in the nervous system, such as seizures and epilepsy. The destructive effects of COVID-19 in the central nervous system are mainly caused by a cytokine storm produced either by the entry of the pro-inflammatory cytokines from the periphery in the CNS or the production of these cytokines in the activated microglia. Secondary seizures may be caused by electrolyte imbalance, oxidative stress, mitochondrial dysfunction, and COVID-19 patient. More research is needed to provide the exact mechanism of seizures and epilepsy in COVID-19 patient. A last couple of slides. Please remember balancing the anti-epileptics in the COVID-19 era. Drugs such as carbamazepine, phenytoin, phenobarbital, which I would say are still the mainly used drug in most of the parts of our country, readily available and cheap, should be used with caution when in combination with remdesivir, which is often used to treat COVID-19. Notably, levetiracetam has been shown to be largely unaffected by COVID-19 drugs. This is what the literature says. And you also all know that the conventional and all anti-epileptics they act on the liver through the cytochrome oxidase enzyme and causes lot of liver toxicity. Consideration should be given to switching to AED with less potential for interaction. On the other hand, changing the AED has been reported as a factor with increased seizure. So that's what you require a neurologist to take care of these patients of epilepsy or seizure in the post-COVID period. Ladies and gentlemen, I wind up by saying that COVID has created havoc. It has created havoc not only for the lungs, it has created havoc for the brain. It has increased the chance of strokes. It has made epilepsy patients. And I must also say that it has made Parkinson's patients also suffer by making them worse. Thank you very much for a patient hearing.
Thank you, sir. Thanks for that enlightening talk. I was especially interested because I run a few epilepsy support groups, and we have noticed an increase in seizure frequency in the last 1 year. And we weren't really sure if COVID has had an actual effect on the frequency of seizures or even the frequency of diagnosis. We really didn't know. But your talk has clarified quite a few things in my mind. So I'll be able to counsel my patients much better now.
Thank you very much.
Yes, sir. Thanks a lot. So we do have a few questions. So I will start off with the first question here. Diagnosis of epilepsy has always been a big issue. With just a couple of thousand neurologists in India and not enough facilities for EEGs or MRIs and CT scans in the smaller towns and villages. So how to diagnose epilepsy, the definitive diagnosis of epilepsy, how do we go about that?
That's a very good question, Dr. Nilesh. The point is, like I emphasized, the diagnosis devolves mainly on the history, what the history is given by the attendants. Because when a person loses consciousness, it is the attendants who have to recall the events that actually led to the person losing consciousness. As we said, there are two types of epilepsies. One is focal and one is generalized. And in certain types of focal epilepsy, the person does not lose consciousness. But when talking about generalized, in focal epilepsies, the person himself will be able to tell, recount the events, and that will make life simpler. The actually ambiguity starts when the person loses consciousness and they do not remember the context in which that event happened. So we have to rely on the attendants giving a history. But if we ask probing questions, like for example, how did it start? Was there any features to suggest an aura? Was there a vacant stare? Did the person lose consciousness? Were there some post-electal phenomena? Whether there was some torch paresis? All this will give an indication whether there's a focal onset or generalized onset. And of course, a systemic examination will definitely tell us other clues. Like I said, in some neurocutaneous syndromes.
Can I come in for it?
Pardon?
Are you through, sir? Sorry.
Yeah. So, so the diagnosis, and like I said, I take recourse to the mobile video recording on a lot of occasions. So this is the clinical aspect. Like I said, we are talking about in a resource-deprived setting, like in rural India and all that. But otherwise, in larger setups, we do go on to do the ancillary tests like a EEG, which could be a interictal EEG record of about 20 minutes. And longer EEG records, we can even go up to 3 days when the person is monitored on the video. And we, of course, an imaging also forms an important part of the work of epilepsy patients. So, but I think your question is primarily addressed as those situations where these sophisticated investigations are not available. But it's suffice to say that even in situations where they are available, the history is the single most important factor when we diagnose.
Yes. Dr. Ranjan, sir, you had a few thoughts.
Yeah, what I would just say is that, and stress again and again and again, that epilepsy is a clinical diagnosis. Epilepsy is not a diagnosis of EEG. EEG only helps you to support your diagnosis because you are recording interictal EEG, and the positivity of interictal EEG is 37 to 40%. So if you are fitting away, you come 48 hours later, your EEG will be plumb normal. My request to my colleague physicians is, please spend time with the patient. As Dr. Narayanan very rightly said, and what I use it a lot now, please, every second person has a mobile phone. Tell him to record 2-3 seizures. It will make your life simple. You won't require CT scan, you won't require MRIs, you won't require PETs, you won't require anything. It is just that you spend time, visualize in your brain the age of the patient, the sex of the patient, the seizure type, the type of the seizure, and if you have the time to talk about the syndromic classification. All of us in our busy clinics don't have the time. And if you don't have the time, you will be causing a hysterical, a seizure, a hysterical, and unnecessarily 1 drug, 2 drug, 3 drug, 4 drugs. At the end of it, the child doesn't even have epilepsy.
Thank you, sir. That was good, because even I have noticed that video recordings have been very, very helpful. Once you record a seizure and share it with your physician, that is one of the best ways to get a definitive diagnosis. I totally agree with that. EEGs are obviously very, very helpful, but very often they do come out negative, falsely negative or falsely positive also. So thanks for that clarification. Another question we have is, this levetiracetam is now coming up as a wonder drug and widely used everywhere. I don't know, is it marketing? Is it good benefits of the medication? Saying that phenytoin is given in emergencies. Can we also use levetiracetam in loading doses during emergencies when people come in with a fit? So,
Dr. Nilesh, actually, for status epilepticus, it has not been kind of validated, but I'm sure. Okay. But there is an injectable preparation of levetiracetam, and now its big brother, which is called breviracetam, which is supposed to have a much higher affinity to the receptors by which the drug works. So these drugs are available in injectable format, but as they kind of the studies which have been used, the drugs have been used for treatment of status epilepticus. Still, the guidelines say that first give lorazepam. That is a very important thing because it acts immediately, and this is to be followed by phenytoin. And if not phenytoin, there is a very simple, a derivative of phenytoin called phosphenytoin, which is water soluble. It works better. So I would implore my physician colleagues to switch to phosphenytoin, which is also very freely available. But you're right. Levetiracetam has taken over the management of epilepsy, in the non-emergent situation almost completely. There is no, great basis to it, but almost all neurologists and physicians are comfortable with it. It works quite well. Its side effect profile is well known. It does have some neuropsychiatric downsides. Some patients do get depressed and they do have problems. But all in all, it works quite well for almost all seizure types. And I'm sure some new molecules like now breviracetam is being marketed very aggressively. Almost 60 to 70 companies are trying to switch from levetiracetam to breviracetam, and that may happen shortly. But having said that, I don't think you should use phenytoin long term. It is a molecule which is effective, but also with a lot of side effects. So I think the side effect profile would tell us that we should not use phenytoin very routinely.
Ranjan sir, please.
Well, I like to question very much that is levetiracetam a real wonder drug? Well, I would agree with Dr. Narayanan very totally here that yes, we had only one broad spectrum, like you have broad spectrum antibiotic. We had only one broad spectrum anti-epileptic, which was sodium valproate. And sodium valproate did work very well in all classes of seizure types, though it was not very effective in focal and complex partial seizures. With the advent of levetiracetam, with the lesser side effects, no titration required, every physician who treats epilepsy or wants to treat epilepsy was putting these patients on levetiracetam. Now, I personally, I'm not in very much favor of this. Just the patient walks into your clinic, you spend 2 minutes with him, you don't care to know whether he has a focal epilepsy or generalized epilepsy, and you put him on levetiracetam. Please do not forget one thing, it's an expensive drug. And you're giving a very expensive drug to a patient for a long period of time. Number two, whatever the medical companies may come and say, I am convinced that 10 to 20 or 14% of patients, especially children and adults who are on levetiracetam, develop higher mental function disturbances, lack of concentration, dementia, mood swings, depression, anxiety. And this is not helped by reducing the dose. So I have nothing against levetiracetam. Now brevacetam has come, 30 companies have come out with that. What is the advantage of brevacetam over levetiracetam? I don't know. I still don't know. I read so much about it. Where does brevacetam fit into the treatment of an epilepsy? I don't know. So really speaking, again, it boils down to newer anti-epileptics will come, keep on coming, keep on coming, keep on coming. But is that what we are looking for in the management of epilepsy on a long-term basis?
Thank you, sir. I've seen that 8 to 10 drugs is what we have for management of epilepsies. Basic drugs are just 8 to 10, and it's just an art of balancing those doses is what management of epilepsy is, in my opinion, in what little experience I have. So yes, this multitude of drugs coming in for the management of epilepsy, we need to identify and choose the best ones. But I think around 20-25% of the patients really do not benefit from any of these drugs. These cases, so-called cases of refractory epilepsy. So is there anything we can do? I mean, surgeries, we can go in for surgery. So who are a good candidate for surgery in epilepsy? Could you just share thoughts on that, sir?
Well, as you very rightly said, the 70 to 75% of patients get managed very easily on a single and a double anti-epileptic. Another 10% by adding another one. Remains a group of patients who are about 15%, which are really refractive epilepsy. So the first question I'll ask my own self, I ask my own son, what is refractive epilepsy? Is there a standard definition by the International League Against Epilepsy that this is refractive epilepsy? To my mind, what the literature says, epilepsy, which is uncontrolled, with 3 or 4 anti-epileptic, broad spectrum anti-epileptic, patient having 2 to 3 seizures per week, affects his activities of daily living, affects his cognition, is a refractive epilepsy which needs to be treated. 1, 2. Now, is this refractive epilepsy a lesional epilepsy, or it is not a lesional epilepsy? Because the surgery which you like to do in an epileptic patient would depend upon what sort of lesion do you have. Third, I would say that, as very rightly said, I would investigate a patient thoroughly, because please don't forget one thing, that working up a patient for epilepsy program is also a major thing. And most of the hospitals may not have a true epilepsy surgery program. But I would certainly stick myself to patients whom I find a lesion, or whom I find medial temporal sclerosis, whom I find cortical dysplasias, localized with EEG correlation, with psychological tests. These patients, I may put them for epilepsy surgery. But if I'm not able to demonstrate an epileptic focus, I have still other two choices that Dr. Narayan talked about: vagal nerve stimulation, now some interest in deep brain stimulation in epilepsy.
Dr. Narayan, sir, your thoughts?
Yeah, I totally agree with Dr. Ranjan. I think he's clarified the situation quite a bit. The point is he's talked about certain categories, and the most common type of epilepsy surgeries for patients who've got mesial temporal sclerosis, because that happens usually in children and young adults who had febrile seizures and usually complex febrile seizures. The lesion is very well localized, and that is a very important part of choosing a candidate for epilepsy surgery, because we must identify the focus very correctly, and the focus, the clinical semiology, the focus on the imaging, the neuropsychiatric assessment, all of it had to kind of corroborate with each other. And that is what Dr. Ranjan spoke about, an epilepsy center. So there has to be, all the facilities for doing all this should be available in the center, and it is a very successful surgery. In persons who are totally refractory, like there are kind of surgeries which are done earlier, like lobectomies, corpus callosotomies, and hemispherectomies. And these are the kinds of mutilating surgeries which have been obviated by the recent advances such as vagal nerve stimulation and deep brain stimulation. And I think these have a future too. In these other types of refractory epilepsies, where the lesion has not been localized, but they're very bothersome.
Yes, sir. Thank you. Sir, I had a specific question for Dr. Ranjan, sir, mainly because I've already heard your talk on that, and I've heard your viewpoint, but I haven't heard Dr. Ranjan on that. This fad of ketogenic diet. So in my support group, there are a lot of questions around, should we follow ketogenic diet? Is it really helpful? Does it have to be totally ketogenic, or could it be like kind of ketogenic? So Dr. Ranjan, sir, your thoughts on ketogenic diet for epilepsy?
I am totally convinced myself that there is a definite role of ketogenic diet. Now, I have also, again, as General Saab rightly said, not used ketogenic diet very much in adults. But in children with the refractive epilepsy, there is nothing known as half-hearted, full-hearted. There is a definite role for ketogenic diet. I can just give you a small instance. We had a patient of herpes simplex encephalitis. God, I had spent 3 months with him. I couldn't control his seizures. Subsequently, I could. And then out of desperation, one day I said, let me try ketogenic diet. I called my dietitian and I told her to advise ketogenic diet. Please, I really tell you that child's seizure got controlled in 3 weeks' time. And today, he's totally seizure-free with absolutely no neurological deficit. After that, I have been using regularly ketogenic diet. In fact, yesterday only, I've sent one patient of complex partial seizures for ketogenic diet. I don't know what is the worth in that, but in children, I would totally agree with Jansa that ketogenic diet does wonders. And if you are doing ketogenic diet, then of course it is difficult to stick by the patient. But the patient has to be very clearly told that you have to do it in the full strength, in the full way, as you're advised by the dietitian.
Thank you, sir. That is very helpful. It will help me in my personal space also. Which brings me to the next question. So, when can an epileptic, somebody living with epilepsy, well controlled on medication, what is the right time to stop the medication? Is there a right time?
There is absolutely a...
Go ahead, sir.
Counsellor, please, sir.
Okay, so the answer to this, Nilesh, is it is not clear cut. There's no one solution which fits all as an answer to this question. There are various. You have to go with the seizure type, the epilepsy type, and the epilepsy syndrome when you arrive at this diagnosis. For example, a person has had a traumatic brain injury, and that scar is there in the brain at all times. So you would not like to stop this seizure medications even throughout life. Whereas on the other hand, there are some conditions in which there is generalized epilepsy. There are no other comorbidity. It is a young patient. The imaging is normal. The EEG is normal. In these kind of patients, we can definitely try to stop the medications maybe after 3 years, 2 to 3 years. And then the chance of a recurrence is never zero. It has to be a shared decision making with you and the patient. And we can tell them to taper off the medicines gradually. And we must also tell them very clearly that they're at the highest risk of a seizure recurrence during this tapering period. And once they're fully aware of all these consequences, and both the patient and the doctor understands the risks of discontinuing the medication in a certain population of benign seizure types with imaging normal, EEG normal, and with very few seizures having happened in the past, we can taper off the medicines. On the other hand, there are some syndromes like juvenile Micronic epilepsy that I talked about. Even though everything is normal, the imaging is normal, the patient is fine, the patient has not had the seizures for several years while on medication, it will be very imprudent to stop medication in these kind of patients, because as per current understanding, therapy for juvenile myoclonic epilepsy is lifelong. So the decision to taper off the medication has to be individualized for each patient.
Ranjan sir, your thoughts, please.
Oh yeah, well, what I do in my practice is that if a child comes to me with a seizure, and I'm sure that every child is already carrying an EEG with him, and most of them are carrying a CT or MRIs also. And you know that we get those single enhancing lesions on CT scans, MRI scans. There are some who have those enhancing lesions. What do you do? How do you stop their anti-epileptics? And what do you do with the other group? There was a very nice write-up in the Annals of the Indian Academy of Neurology to what to do with a single enhancing lesion and anti-epileptics. And the consensus of opinion there was that you do a CT scan 3 to 6 months down the line. And if the lesion has disappeared, you could even stop the anti-epileptics. And that is exactly what I do. The other situation is the normal CT and a EEG. Then what I do is if the patient has had 1 or 2 seizures, I go with the family history of seizures, any mental retardation, any delay in the milestones, any other comorbid conditions, what is the type of seizure, how long does it last, and if the seizure is a single generalized seizure without a focal onset, he's had 1 or 2 seizures, I'll treat them with anti-epileptics for a period of 2 years. Lots of studies do say that EEG should be taken as a parameter, but I don't know whether that is the gospel truth. But suppose you get an abnormal EEG at the end of 2 years, I continue the anti-epileptics, repeat another EEG at the end of 6 months. Nilesh, you will ask me, if 3 EEGs continue to be abnormal, will you continue anti-epileptics? Answer to that question, I don't have. But if the child is all right, there is an isolated discharge here and there, I will totally taper off the anti-epileptics and take him on. But my request here is to all those who treat epilepsy, please remember monotherapy, monotherapy, monotherapy. You will again see people entering our office in the Apollo Hospital with dual or triple anti-epileptic therapy because they think, the clinician or the GP thinks that if he gives 3 anti-epileptics, the fits will get better control with a single anti-epileptic. And all the 3 epileptics are in subtherapeutic dosages. So monotherapy, do an EEG, wait. If the EEG shows epilepsy, I don't worry about it. I take off the anti-epileptic. Now, the next question the family would ask, certainly, what are the chances of his having another seizure? I honestly tell them that I am not curing epilepsy. I am only controlling the epileptic discharge. I'm not playing around with the molecular basis of epilepsy. So please, your child has a chance of 5 to 10% of having seizure even 20 years down the line. And I still advise them not to let the child swim and not to let the child drive heavy vehicles.
Thank you, sir. I was hoping to close this here, but I still have questions coming in from all our doctors. So I would like to take those questions because I think they're important. We have talked about so many anti-epileptics, but somebody wants to know the role of clobazam. So we haven't really spoken much about the role of clobazam in treatment of epilepsy. Could you just share some thoughts on that?
Well, I would say that the clobazam that comes as frisium is a fantastic drug. And where does it fit into the treatment of epilepsy? That's what you want to know. I think as far as I'm concerned and what is the literature says, that as a patient comes to you with an epileptic seizure and you're starting an anti-epileptics, and most of the anti-epileptics, except for levetiracetam and some other, require a gradual increasing of the dose. Whether you use carbamazepine, whether you use phenytoin, whether you use oxycarbamazepine, whether you use lamotrigine. I'm pretty fond of lamotrigine, but then you would take 4 to 5, 6 weeks really to reach the dose of lamotrigine which you want to do. So here, frisium or clobazam is a wonderful drug. You can use it, start it, but then there is no point continuing this drug more than 6 months because of the addictive nature of this thing. Otherwise, I would say for acute epileptic management, it's a good drug.
General Narayan sir, one specific question for you. So I'm in your Manipal hospital emergency mein I am working, and this patient, I get this patient coming on the trolley, first time seizure, no history, unprovoked seizure. He was at work doing some typing and he got a seizure, got into the ED of Manipal hospitals. How do we manage this? Do we do the same thing as lorazepam and phenytoin? Do we send him back home with AEDs? How do we manage a first time unprovoked seizure who comes into your ED?
Yeah, that's a very good question. As I said, firstly, if it is a first seizure, we have to find out whether it's a provoked seizure or an unprovoked seizure. That is a very important thing. And most commonly, when a young person is wheeled into the ED, there is some cause of provocation, for example, alcohol withdrawal or some such thing is there. And suppose there is a history of some provoking cause, then we know how to deal with it. Then we don't have to go by that lorazepam and phenytoin and shifting to the ICU route. The second kind of a situation is if you think that there is a problem, as I said, even if it is a first seizure, you do have to do all the workup to find out if there is an underlying pathology or not. So you have to do a complete blood count. You have to do metabolic profile. You have to do the liver function test, kidney function test, thyroid function test to find out if there is an underlying cause in that patient. And as I said, it is a very underused kind of a thing, but I use it routinely as a urine drug screen as well in young patients who come with a seizure. Then we do always proceed on with the investigation, and we could either choose between a CT or an MRI. An MRI would be much better, and I don't see any reason of choosing a CT over an MRI. So if the person has got normal blood counts, normal metabolic screen, and his normal imaging, so that is when we said a single unprovoked seizure, and the person has got no antecedent comorbid illnesses, then we can very well not treat him. Because as I said, the risk of a recurrence is 15 to 70%. It is on the lower range of 15% in those persons who have a single, even if it is a provoked seizure. So that means there is unprovoked seizure. Suppose the person has not any kind of precipitating factor, the chance of a recurrence is only 15%. So we do not give any anti-epileptics to these patients. That is a standard guideline, but it is a shared decision making again. Some patients may not find this risk of a recurrence even 15% acceptable. Then we do put them on anticonvulsant therapy. And subsequently, of course, if the person goes on to have another seizure, then it becomes epilepsy, then you have to manage as such.
Yes, sir. Thanks. Thank you. So this has been a very, very personally satisfying webinar for me on a subject very close to my heart. And talking to both of you, General Nayan sir and Dr. Ranjan sir, it's been a great pleasure. Thank you for being on this webinar. I hope to see you guys personally very soon.
Thank you very much.
Nilesh, it's wonderful meeting you, and thank you, Ranjan sir.
Thank you, sir. Thank you, Nilesh.
Thank you, sir. It's been great, sir. Bye-bye.
Bye-bye.
Bye. We close this webinar now. Thank you.